It's a real pleasure to be with you all this morning up here in Canada. It's a cool morning, minus 15 degrees or so in Toronto. So, but glad to be with all these warm hearts. It's a real privilege for me. This is my first time hosting the Global Cafe, and it's a real privilege to get to introduce to you Dr. Yuka Summi. Dr. Yuka Summi holds an MD from Kyoto Prefectural University of Medicine, a PhD from Osaka University, Japan, and MPH from the London School of Hygiene and Tropical Medicine. She's a certified specialist in acute and critical care medicine. She has worked as an associate professor in the Department of Emergency and Critical Care Medicine and in the Faculty of Gerontology at Juntendo University. In 2016, she joined the Healthcare New Frontier Promotion Headquarters office in Kanagawa Prefectural Government in Japan as a global health senior project leader. And since December 2016, she has been responsible for a WHO integrated care for older people, ICOPE, and developed the ICOPE implementation tools, including the freshly released second handbook. She's is a secretariat of the WHO Clinical Consortium on Healthy Aging to contribute to the development of standards and guidance on the clinical aspects of healthy aging. She, under the CCHA, she coordinates activities such as ICOPE implementation in countries and ICOPE training for health and care workers. She's also led the development of WHO guideline for non-surgical management of chronic primary low back pain in adults in primary and community care settings, and the ICOPE Handbook Second Edition. Well, welcome to you, Yuka.
Thank you so much. Good morning, good afternoon, good evening, everyone.
Well, you know, Yuka, you have such a rich background, and not always in public health. You were working right on the front line. Tell us a little bit about yourself and what led you to the work you're doing now.
Thank you so much for your kind introduction, and very good to see you. Some familiar faces and some new people I've never met. This is a great opportunity to get to know each other and then to present WHO ICOPE approach. But first of all, thank you for asking my bit unique kind of career path. So I started actually working in the healthcare field as an emergency and primary care physician in Japan, and worked in the university, teaching hospital, taking care of patients, teaching students, and doing clinical or basic research. And in the emergency department, actually, I have witnessed that there are some aspects in older patients that we are talking about today, and that is strongly influenced by social issues as well as really affected by the public health. So this is not only about individual care, but also the importance of the public health. That is a point I started to have an interest on how it looks like, how can I be helpful to provide the better public health for the people. I'll give you an example. Sometimes older women living alone calls ambulance every Wednesday after midnight due to the loneliness. And because she has a lot of chronic conditions, we need to do the full checkup. We never find any issues why she had a symptom at that night. But somehow every Wednesday night she comes back, and we becomes a good trust relationship to find out why she's calling the ambulance, and then find out that because she has she's living alone, she has a loneliness issue, and how we can connect to the social support. Another example include older man repeats to come back to emergency room due to falls in his home, and without any intervention after the first incident. What if we have a good public health to prevent next fall and to understand what is the environment issue, what is the issue, why he is coming back to the fall, to the emergency room because of falls. So this kind of the opportunity actually brought my attention to what can we do as a public health. Mm-hmm. I was also privileged to take care of patients in primary care clinics, where the majority of patients, because I'm from Japan, were older people. I enjoyed listening to their voice, including concerns what matters to them, and how to provide person-centered care. As a physician, we are trained to diagnose diseases, monitor diseases. Talk about hemoglobin A1C, which is diabetes, data. But when you ask what matters to older person, this is not about the number of hemoglobin A1C. But the reality is, I want to keep going to see my grandchildren, or I want to keep singing classes. So this is coming to the really about person-centered care, listening to their voice, understanding values and priorities. And lastly, I will talk about disaster, climate change. So Japan is earthquake country, unfortunately. So when the Tohoku Pacific Ocean earthquake happened in 2011, I was a part of the medical support team and went to the evacuated place. And there are older people losing all the prescriptions he or she had, and then not being able to continue to take care of their diseases. And then again, I was convinced by the importance of the public health, even during the disaster or any climate change. Fortunately, afterwards, I got the opportunity to work in local government and later seconded to the aging unit in WHO Geneva. Today in Geneva, it's sunny, around 6 degrees, and very happy to be here. Thank you so much.
Thank you. Thank you. It is amazing, the social determinants of health. They so often just get overlooked, and yet it's up to 80% of the determinants of health are in fact social, and the way that we the wholeness of how we're integrated in an ecosystem of care and health. So that's amazing that your experience on the ground and you're witnessing and trying to wrestle with problems firsthand is what really led you to make to seek out that global public health impact to address many of those questions. You're at the WHO. We're halfway through the decade of healthy aging. We have the 4 action areas: changing attitudes, age-friendly communities, long-term care, and of course, integrated care, integrated care of older people. Why is that so important for the decade? And why is it so rooted as one of the 4 action areas, do you think?
Yeah, thank you for highlighting the decade of healthy aging. It is already halfway. So there are, probably many of you already know, but decade of healthy aging is a really transformative collaboration of diverse sectors and stakeholders to improve the lives of older people and families and communities where they live. So when you talk about health and well-being and older people, this is really important. The integrated health services is available, accessible, acceptable for the people. And these services needs to be really good quality. And in reality, there is a lot of challenges happening. For example, shortage of the health and care workforce, lack of skills and knowledge of this healthcare workforce. The prevention to the promotions, treatment, rehabilitation, palliative care, all throughout the life course, we call it continuum care. It's so important for older people. But the reality is both older people themselves and healthcare workers may not think, prevention and promotion is good for the older people. It is. At any age, it is important to start prevention, promotion for the decline of the physical and mental capacities, for example. When we age, in this webinar, everybody ages every minute, right? It's not about somebody else we are talking about. It is about us. It is about your parents. It is about your grandparents. So when we age, our physical and mental capacities tends to decline. We are talking about vision or hearing or depressive mood or cognition or mobility or nutrition, different domains of intrinsic capacity tends to decline. But the speed of the decline is very different among individuals. So how can we actually prevent and promote to maintain the intrinsic capacity? And that requires person-centered care. So when the person has a bit of decline of capacity, how can we actually support, maintain the capacity? We are not talking about just the diseases, but also the capacities and abilities. And then when you have a significant loss of capacity, how can environment support maintaining the function despite the decline of intrinsic capacity? So in that sense, integrated care for older people is so important, critical area, action area of the decade of healthy aging. But having said that, how about the other three action areas? These are actually really interrelated. Addressing ageism among older people as well as health workers to have a quality healthcare. We call it internal ageism. Oh, I'm too old to do the physical exercise. I'm too old to train my cognitive function, which is not the case. We really need to raise awareness, provide the self-care and self-management opportunities, as well as training health and care workers. Since I was working in the primary care physician, I actually regret how I have been taking care of older people. I used to take care of the diseases, very silo, but the reality is you need to think about more on the capacity, diseases, environment, and combination of the together to provide a person-centered care plan. How about the age-friendly environment? Environment is everything outside of our skin, meaning assistive technologies, like I have a reading glasses, mobility aids, safe road. That is also important with the good light and the safe road. So how this environment can facilitate access to the healthcare, do the good health promotive activity, physical activity. So all are related. And finally, long-term care. Integrated care is about continuum care, as I said, from the high intrinsic capacity to the low intrinsic capacity, the person who requires assistance from others. So this is really important. The four action areas come together, work together, even though today's topic is more for the integrated care for the people. Thank you.
The ICOPE reflects this continuum of care that is to address and reorient health social services to this person-centered and coordinated model of care. Can you kind of expand a little bit on this intention, and how does it relate to the social determinants of health and programs like social prescribing, for example? Or actually, perhaps let's start, but maybe you could paint a picture of what older people experience when they do not have such a continuum of care, or health and social services that are not person-centered or well-coordinated. What does it look like on the opposite? Give us that sense of what that's like, and then
Thank you so much, Gregor. Very important question. So let's imagine your grandmother or mother, 75 years old, living alone. She might have a high blood pressure, taking one medication, occasionally go to the general physician to take, to monitor the hypertension. She can do everything by herself and enjoy going to her singing class every week, and actually helps you to take care of your children or your grandchildren. That is the high intrinsic capacity, right? One day, she falls accidentally at home, and she needed hip replacement and rehabilitation. If you are living in high-income country, she might have access to the rehabilitation services, acute care to the rehabilitation services. But after a few months of the rehabilitation service, she was sent to the home, but she started to lose her mobility. Once you experience the fall, you might lose the confidence to go out. What if it happens again, right? She lost her confidence and go out less and less. She felt lonely, spending time alone. Later on, she started to show signs of cognitive decline. And you as a daughter or son, you brought to the GP, or my mom, my mother, or my grandma start forgetting. And then the doctor said, oh yeah, but she's taking medication for the hypertension. Okay, let's check if she has a dementia. Oh, there is no dementia. There's nothing you can do. And then she was sent to home. And then you started to worry everyday life. You need to support and assist in her everyday life. However, you have a full-time job with 2 kids. So how you can balance to supporting your mother or grandmother and then supporting her healthy aging? So what if she does not have any access to the continuum integrated care? She could not have access to intervention to prevent decline or maintain her intrinsic capacity, which is, for example, multimodal exercise. Having the good protein nutrition to build her muscle, she needs to gain the muscle strength. And she might actually benefit from the cognitive stimulation before cognitive decline manifested. And then maybe the health workers, the GP were trained to diagnose diseases, treat her hypertension, but not necessarily understand, okay, how to take care of her intrinsic capacity. She could not have access to the walking aid or rehabilitation services. She could not have access to the home modification after the fall. This the fear of fall, why this fall happens. And if you have a good rail or, the safe environment at home, that's already really helps her to do some exercise at home. Maybe feel more confident to go out. And she could not have an opportunity to engage in social activity in the community when she felt alone. So that is, imaginary scenario, but still, I guess everybody can imagine that could happen in your country, regardless of the resource settings. So integrated continuum care is so important, not only the so-called medical aspect, but also incorporating social care and support aspect. So in ICOP, actually, addressing social care and support, as well as need for the carers, many times family members, many times female, these people needs to be trained and supported. And then listen to her voice, what she wants. Her goal might be continue to go to her singing class. So as you mentioned, social prescribing. Social prescribing is a means of connecting people to a range of non-clinical or non-medical services in the community to improve their health and well-being. And that can be used as a way to address social care and support needs. That include, of course, depending on the local context and availability of services, some social services for the welfare, financial or housing support, or food security, or something support for the survivors for abuse, or social activities, employment or voluntary activities, or some lifelong learning and education services, and of course, access to the healthcare and health promotion services. In some urban areas, maybe opportunities for spending time outdoors and culture-related activities. So these are the things we could do as a community to support, not necessarily traditional medical services, but also more for the social services in the community.
And it's resourced together. So it's systematized. So we work with our physicians and we have programs. So it's not just happenstance or wouldn't it be nice if, but we actually resource capacity to build that wrap of care around an older person. We do have a couple of questions that have come in, but I'd just like to ask one more question before we get there, and that is, you've just launched the ICOPE Handbook 2. So can you explain the key objectives of the new ICOPE Handbook, how it differs from the first? I notice there's an app even for you can get an iCope, you can get the app, and it talks about these 4 steps of the iCope care pathway. Maybe just give us a little summary of that and how we can use the handbook and the app.
Thank you so much. So the ICOP handbook is a really technical resource to support health and care workers to put evidence-based recommendation into practice in your primary care, including the community. The handbook really describes practical care pathways from step 1 to step 4 that's to be adapted for your local context to detect decline in intrinsic capacity, detect the social care and support needs, and develop the personalized care plan with older person, and then if needed with carers. It really addressed the decline in intrinsic capacity we just talked about: cognitive decline, loss of mobility, vision impairment, hearing loss, malnutrition, depressive symptoms, and key factors in older people's health that include social care and support, carer support, and the newly included is urinary incontinence, which is often underreported and stigmatized. And these all different issues needs to be supported in an integrated care way. So this is not about just the listing all the issues, but to understand what is a priority, what matters to the older person, what is the clinically urgent things we need to solve. So since the first edition in 2019, we have really learned from the field in terms of the accessibility, acceptability, adaptability of ICOP, and also the usability of the handbook in different resource settings. As a clinician, I really want this resource to be useful and adaptable and flexible to adapt to the local context. So in this second edition, after 5 years, we reflected these learnings and further integrated the latest WHO guidance of relevant health topics. For example, there are new topics. Oral health is included in the ICOP handbook. And as I said, urinary incontinence is part of the ICOP handbook. So social prescribing is part of also the social care and support. So to understand what is needs to be, it's just one place you can look at it to address the different needs of the older people. So just summarizing, because it's a big handbook, and then I would recommend you to take time to look at this handbook. Summarizing key point that has been changed is, so before it was actually 5-step care pathway. Now actually 4-step care pathway. The reason was 5 steps. 5th step was community engagement of supporting and carers. And we recognize actually community engagement and supporting carers should not be the last step. That needs to be all steps embedded.
Right.
Part of the pathway. And then first step is before it's called ICOP screening. Now it's called the basic assessment. And that includes not only the testing, the intrinsic capacity, but also the provision of information, health and social services, and support at the first point of contact with the older person. And this is really important, especially in low resource settings. So when older people do not necessarily go to the healthcare facility to seek for the healthcare, but rather in the community, close to older person, you could identify the needs of older people immediately if you find the needs to connect to the resources available. And that can use to promote the healthier lifestyles. So there is a bit of the more focus on the health promotion and the health prevention, as well as identifying social support needs. So loneliness can be identified for the first contact of the older person. Vaccination can be actually promoted on the first point of the contact. So there are many things you can do at the first point at the same time of the assessment of intrinsic capacity. But having said that, we are not kind of ignoring after the step 2 onwards, which is step 2 is in-depth assessment in primary care. And then step 3 is developing a care plan. And then step 4 is implementing monitoring. So the step 2 onwards, most likely we need health care workers with knowledge, with some training. But the step 1 can be done by anyone who has a short training. There are a lot of examples coming from the different countries. For example, in Kenya, health promoter who are the lay people, but they are trained to support older people. They are conducting a step 1. In Cambodia, older people association are actually supporting the step 1. So this is a really opportunity to engage more people, more audience, not only the traditional healthcare worker in the facility, because when we talk about care for older people, lack of workforce always as a challenges, but actually tapping on the existing resources in the community is the opportunity to support older people. Then having said that, it's linked to that community engagement. As explained, this handbook really expanded target audience to the community stakeholders, not only the traditional healthcare worker at the facilities. And then I just talked about step 1, but not only the step 1, example of what community stakeholder can do at each step are included. And then the fourth point is really recognizing the role of carers, and greater attention to their support needs is given in this second edition. That include the provision of information and training and support for carers' health and well-being. Caring for the one person who are completely care dependent is really tiring and can be really exhausting. So how can we support these carers? And unless you have a very strong long-term care system, many people, the carers, are informal family caregivers. So how can we support these carers? It is about information, it is about available training, it is about respite care. Time to time, they need to kind of shoulder needs to be, burden off from the carers. How can we support this kind of respite care? And then finally, the earlier identification of social support needs, carer needs, and the inclusion of the urinary incontinence. Thank you.
Wow, that's very, very comprehensive and really exciting to have such a user-friendly tool to be used, vertically and horizontally through all of our systems. It's useful for medical practitioners, unpaid care workers and volunteers, frontline workers. That's really exciting. Excuse me. On that note, we have a couple of questions. One from Shmuel. Thank you, Shmuel. How, according to your continuum of integrated care, can support improvement of health of older persons from poor and low socioeconomic groups of the population? And similarly, Malor Kodi says, most of the time, the healthcare system at low and middle income countries are fragmented. This makes integrated care challenging. How do you suggest to incorporate ICOPE in these kinds of situations? So they're kind of similar questions, kind of getting at the same thing. What do you think?
Very valid point. And we are actually learning also from the field where the resource is limited. So first of all, how actually ICOPE can address the equity issue is, are we actually reaching the older people who are most marginalized or disadvantaged because of the socioeconomic status? So the reason the ICOPE is about is community-based, primary care-based, which is where older person lives. So as I explained in a different country experience, at the moment, it's not a country, the big stage, starting from the small community, in the community. There are the different experience from Kenya to the Thailand to the Cambodia. Actually, these community stakeholder is the really empowering resources leads to the older people. So health promoter in Kenya actually did the home visit in the village, one by one, to do the ICOPE, especially step 1, and to identify where older person with needs, and then to support specific needs for older people. And then we were told ICOPE is the first technical resources to address the specific needs of older people. many countries have, for example, NCD prevention. That is for adults, all adults, right? Not only the older people. But ICOP is really understanding diverse needs of older people, incorporating social care and support needs. So when you visit, it may not necessarily the healthcare needs, it might be the livelihood needs. Oh, basic needs is not met. They have lack of food. They have lack of access to the food. So that can be also picked up because this is a very holistic assessment to understand the diverse needs of older people. So this community-based aspect is really the key to address the equity issue, to reach the older people. But at the same time, I'd like to acknowledge there is still the huge gap in terms of universal health coverage. Meaning universal health coverage is provide a quality of care without financial burden. So coming to again, the Kenya's experience, when they identify the needs of the healthcare, they need to connect to the primary care, right? So to bring the primary care to do the formal assessment or formal treatment, but they don't have access, they don't have a transportation. So the community health worker or community volunteer is the one who drive to the primary care. And then when you go to the primary care, actually many healthcare workers might not be equipped or trained to address older person's needs. And so there are still a lot to do. And then especially, for example, access to the assistive technology. Some countries, assistive technology is free of charge for older people, but not all countries, especially hearing aids. Reading glasses becomes more and more accessible. Mobility aids becoming more and more accessible. But coming to the hearing aid, which is very good, effective intervention, and the hearing loss can be really related to cognitive decline. That might be out of pocket for the older people, which is not accessible. So there are still a lot to do in terms of the health system strengthening, especially primary health care, universal health coverage. But at the same time, it doesn't stop us to start implementing ICOP. There are many things we can do together with the community to provide the care. So when it comes to the fragmented care, that is very important point. Fragmentation is happening actually not only in the low and middle income countries, actually more in high income countries, because they are so sophisticated. They have, this is our territory. This is the way that we provide the care. So that is actually common issue between the low and middle income countries, high income countries. And I found that ICOP is the opportunity to bring different stakeholders together. So again, coming to the community, their community, they know each other if it's rural area, not the urban area. Now urban area, there are more and more fragmented and the more older people are isolated. But when it comes to the rural area or village area, they are already some kind of network exists. But the decade, we talk about decade, what is decade is about, is to connect diverse stakeholders to support older people. So the health of the older people, and today we are talking about healthcare and services mainly, but not only health sector, but also social sector, transportation, education, the environment. So all the sector needs to work together. This is not only purely about the government responsibility or government can do, it's about healthcare workers, this is about civil societies, this is about private constituencies. Everybody needs to together, but not to forget to the what older person wants. So we really need to listen to the voice of older person, co-design the care, so that the care is actually accommodating older person's diverse needs.
Yeah, that's a really great point. So, nothing for us without us, as we say. and including the voice of older people in the decisions that affect them and in their own health. So important. And actually, that kind of leads to a question by Mr. Sherlock, Brendan. Maybe you'd like to speak to your question, Brendan. It says, he asks, is integrated care person-centered or driven by system care? Maybe would you like to expand on that for us a little bit, Brendan?
Yeah, I'm just wondering how the person is actually given their side of the story. Let's put it that way. It's a difficult one to ask. Is the person the most important thing, or is the system the most important thing? Maybe that's what I'm trying to ask. Thank you.
Well, such a valid point. Thank you so much for your question, Brandon. My answer is actually both. The person-centered care principle coming from the older person's voice. Listen to their voice, listen to the needs, listen to their priorities. But when it comes to the healthcare services, social care services, integration, that does not happen, just listen to the voice, right? So reality is you have to work from the micro level. So it's a clinical care, patient encounter, to the service delivery, which is more for the service coordination, including data sharing, information sharing, capacity of the health workers, to the system levels, how this actually supported by the law, policy, action plan. So where actually WHO, when we talk to the member states, which is most of the time the ministry level or the government officials, we say that we need to work 3 levels together, from the patient encounter, older person, the more everyday clinical care, to the service delivery, kind of restructuring service delivery, not putting just a new service on top of it, but identify where is the entry point and how we can actually reshuffle and task share or task shifting to do the integrated care, to the how you can support the system that comes to the, for example, universal health coverage, how system is protecting the right of older people, how system is supporting healthcare worker to access to these learning or training. So the answer is actually both, but thank you for highlighting this point.
Thank you. We've got a lot of questions here, which is really great. So I'm just going to try and do our best to get to all of these questions. One question is from Maruna Dinescu. She asks, what about including oral health for geriatric people? Is oral health part of the ICOPE program? Oral meaning,
Yes.
Yeah.
Yes. So actually, thank you so much. So the good question. When I was taking care of patients, actually, I said, keep the older person eating. But of course, we need to consider what kind of nutrition he or she needs to take, because having something by yourself, even with support, the eating is so important for as a human being, right? I like to eating too. So the oral health, recently WHO actually got the resolution to support oral health. So integrated care for older people, of course, everything needs to be evidence-based intervention. And then one of the domain of intrinsic capacity is malnutrition. When you talk about malnutrition, is not only the obesity or the overweight, but also undernutrition. When you get older, your protein absorption is getting lower, your muscle mass getting less and less. So it's really important to have a good nutrition. So to get the good nutrition, you have to have a good oral health function. It's not only about chewing, but also swallowing. So this is really important issue. So we worked together with the colleagues in oral health, and under the malnutrition section, we actually highlighted the importance of the oral health, how you may be able to identify the needs of oral health issue. But coming again, universal health coverage. So what's happening to your country to have, for example, dentist appointment? Is it free of charge? Is it the same as a healthcare? So many countries, even including high-income countries, somehow oral health is not part of the universal health coverage. Many times you have to pay out of pocket in a very substantial fee. So we are really working on it, how we can support oral health, part of universal health coverage, how healthcare worker, the not necessarily dentist or specialist, can support or identify the needs of older people in terms of the oral health. And when we talk about nutrition, of course, this is not only about food, but also hydration. So in nutrition section, there are one more section around how to address the hydration. That is also linked to the urinary incontinence. So if the older person has a urinary incontinence, they tend to save taking fluid, right? Because they don't want to have any episode of the urinary incontinence. And that leads to the dehydration. And that might lead to the urinary tract infection. So we really want to have a bit of a holistic approach around the nutrition, including oral health, nutrition, and the hydration issue. Thank you.
You know, we had the experience even in a wealthy country like Canada, for low income people, that there was a strong correlation to isolation and loneliness and oral health, that people just embarrassed of their smile, that they don't want to engage they don't want to engage socially, and they just decline, and the decline can be very quick and exponential, and that they just self-isolate with a crippling loneliness. That so we began working in some programs of bringing in oral health workers to support basic cleaning and taking care of your teeth. But it is a big question, because which really speaks to the life course continuum and universal healthcare, that dental health is something that is long term. It needs to be addressed throughout the life course. As you know, it can be very expensive to just address some kind of massive change at the end of life. But it's interesting, the intersection of that isolation and loneliness and participation in society because of a lack of oral dental care.
Yes, thank you so much for highlighting this. I also actually echo what you have said around, the losing teeth or something like that. Actually, some older people think this is part of normal aging, and which is not the case, right? I forget things, or my knee hurts, so I cannot go out as much as I used to. That is not the normal part of aging. Actually, you can do something about it, right? The prevention, promotion, as we highlighted around dental or oral health, the risk factors is really same as, many things are same as a NCD, non-communicable disease risk factors. Hypertension or diabetes, obesity, these are the really common, risk factors for the oral health as well. So if we can promote the aspect of the preventing non-communicable diseases, actually that would also help to prevent oral health issue. So in the end, it's really the holistic approach, not by diseases. So, I understand to highlight, okay, how about dementia? Or how about joint issue? Or how about oral diseases? This is important, but when it comes to the integrated care, many intervention actually overlaps, and many intervention has a positive effect to different aspect of the issue. So that is really the point why we are providing integrated care. This is not only about person-centeredness, but also the effectiveness of intervention to consolidate, to understand the issues, and then provide an intervention in an integrated way.
Building it's person-centered, but it's also about building that ecosystem of well-being and health throughout the life course. Very interesting. I'm just going to continue on, Yuka. We have a few more questions. It'd be great to get through them all here. So maybe we can try to briefly address them as we go. David Richardson asks, in Canada, the public healthcare system is under considerable strain with the shortage of primary healthcare doctors. Amen. I can't find a doctor, David. I've been 3 years. I can't get a doctor. Can imagine long wait times at emergency departments, underqualified and underpaid staff at long-term care homes, taking up so much of the public dialogue. How can the continuum of integrated care get the attention and support it needs in these current circumstances?
Thank you so much, David, for your question. In reality, not only older people's health, globally, healthcare workforce, the number of healthcare workforce is lacking, right? So it's really compared to healthcare needs, the amount or skills of the healthcare workforce is not, there is a huge gap between these two. So there are two things I can, it's not immediately solve the issue, but we can actually address. So first thing is the way we approach older people can be really multidisciplinary. So traditionally, physician takes all the decisions, physician takes all the things, doctor does things. But that's not the case for older people, actually. Multidisciplinary team approach is we are promoting that actually support the task sharing and task shifting. And of course, these people need to be paid and trained. So the one we are working with member states is how can we build the capacity of the multidisciplinary team? How can we share the task? Of course, many countries, there is a regulation. Doctor needs to do this intervention. Nurse can do this intervention. Pharmacist can do this intervention. How can we actually change this regulation so that they feel confident and skilled? At the same time, they can provide the quality of care. So some example, it's not from high-income country. In Sri Lanka, they actually started to have a public health nursing, and they are expanding the number of public health nurses. And they take care of the children to the older people. So they are the one working with the physicians to go to the field, to go to the home, to identify the needs, to provide the care, and then if needed, report back to the physician, and then discuss the care plan, and the she or he is the one go to the home to provide the care. So that is the one model that in low and middle income settings doing. But at the same time, there are also the tendency that, or more empowerment in terms of community stakeholder we were talking about. The volunteers, older people associations are working towards supporting older people. But these people are not always sufficiently trained, and they are the volunteers. So we need to be a bit careful what is the responsibility of the health system and what is the responsibility, what are we expecting to these volunteers. These volunteers need to be protected and trained. And the second point I wanted to raise is when we talk about older people's care, many member states said, oh, this is a financial burden. That's the immediate reaction, right? But the reality is that Gregor said about prevention. If we can work on the prevention and promotion in earlier stage, life course, through the life course, that will minimize the future outcome or future care cost. Many member states talk about, oh, what the cost for the long-term care? We don't have money for the long-term care facility, lack of care workers. But if we can work for the trajectory way, not just that, one point of time to disease diagnosis, just fix it, but more for through the trajectory of the aging, to start with the promotion and prevention to minimize the outcome. But the reality is not many countries see the long-term outcome, and they don't see it. This is an investment. If you could do the prevention promotion throughout the life course now, actually, this is the investment for the future health and care needs. But at the same time, we should not forget the older people who requires long-term care. They need to be supported, and then they need to be supported to live with dignity.
Yeah, that's great. Another really kind of a related question here is from Mal Arkady. He asks, can patient do self-administration for the phase 1? And if yes, if there are any red flags identified, what would be the safety mechanism? What if you get it wrong? And how would they be validated or evaluated?
So given the technology advancement, there are increasing interest, self-care or self-check of the step 1 using the technology. For example, in France, there is a mobile phone app developed by themselves to do the self-assessment for the step 1. We still need to evaluate what is the result. Is it comparable compared to healthcare workers' assessment? But at the same time, one of the aspects we need to consider is self-care or self-assessment empowers older person, right? So periodically check their condition, their intrinsic capacity level, actually encourage them to do the health promotion by him or herself. So in France's case, actually the nurses is by phone to support the first time the step 1. And then if the nurse thinks that person or with the support of the family can do the self-assessment of the step 1, they let them do it and then periodically check if there is an alert on that. So still in terms of science, is it actually valid compared to the healthcare workers assessment? Still the evidence needs to be built. But at the same time, we see the really positive effect in terms of self-empowerment to take responsibility, take ownership of their health in terms of intrinsic capacity. So yes and no, we still need to be, we still need to build the data. Can we substitute or can we replace it for the step 1 only for the self-assessment? But at the same time, I think we see that, okay, self-care, self-management, probably this is the important kind of one of the methodology to encourage them with the supervision of healthcare workers.
Oh, that's rich. That's rich. I would draw everyone's attention to the chat as well. The comment made by Oyunkand Ragcha, who points out that in 2024, amendments were made to the law on the elderly in Mongolia based on the ICOPE. That's great. So it's really made an impact at a country level, which is really exciting. I believe it's Eileen from Ireland asks, how can the ICOP framework and steps be incorporated in the hospital emergency department? Is that something that are they too far apart, from the continuum of care? Is it integrated care? How does that into the emergency room?
Ooh, that's actually very close to my heart question, knowing I'm coming from the emergency department in a hospital. At the moment, WHO does not offer the technical guidance how to incorporate in the emergency department. But actually, why not? Why not we start piloting and then showcasing that what can be done in emergency department? I actually, started with the example, right? The older person coming to the emergency room because of loneliness or repeating falls. So what if after the emergency admission, if the healthcare worker at the emergency department can apply the ICOP approach, in maybe the bit of the customized way to identify the needs, even though the acute episode has been fixed. But if you can identify social determinant of health, that might actually increase the chance to come back to the emergency room, or that might actually has an opportunity to intervene, to provide a prevention intervention, why not? I'm happy to actually engage and to understand how we can do together.
Wow, that's really exciting. Well, Yuka, this has just been, we've still got lots of questions in the chat. We could really feel like we're just starting this conversation. It's just so exciting. Just a couple of weeks ago or 3 weeks ago, we had one of our colleagues with us, Sonia Sung, talking about social prescribing in Canada. And this is just ringing so many bells and really taking a holistic approach to the life course and looking at the whole person and how we can really create that, you know, an ecosystem of well-being for our whole life, the whole life course. This is just really exciting, and to have such a practical tool that I suppose will continue to evolve as more evidence, as more experience, as you're learning more. There's probably going to be a handbook 3 as we continue to develop it out. So thank you so much for your incredible work here and your leadership, and for this great conversation today. It's really been exciting. Thank you so much.
Yes, pleasure is mine, and it was so great to hear the different comments and questions. And you know, WHO is really supporting people globally, right? And you are the one close to older people in your community, in your health system. You know better than me. So as a person who is sitting in WHO headquarters in Geneva, I really appreciate your feedback. What if, can we do this? Can we actually, you know, this is lacking, there is a gap. How can we do this? And these kind of feedback always welcome. And then share your experience. And I didn't know about Mongolia case. That's really glad to know. And then hopefully throughout the decade, we still have 5 years to go to improve the older person's lives and their families. And it's about you and your family and the future older people. Thank you so much.
Thank you, Yuka. And on that note, we just invite everybody to join us in South Africa, September 9th to the 12th for the IFA 17th Global Conference on Aging. We'll have many speakers with us from the WHO talking about the decade, really including Alana Officer and others. So we really welcome you. Please submit some abstracts, register now, get that early bird registration fee. There's no time to lose. So please register and join us in South Africa. Named the #1 destination to visit in 2025. So not to be missed. Please do join us, and the Luana will pop the link for that into the chat. Thank you, Luana. Just to remind everybody that next week we're excited to welcome Dr. Carrie Neiman, celebrating World Hearing Day, a focus on healthy hearing as we age. So thank you all, and wishing you a wonderful week ahead. And thanks again to you, Dr. Summi and Luana and the team. Thank you all for joining us.